You can begin. We are live.
Dear colleagues, dear friends, I am Konstantinos Tsioufis, Professor of Cardiology at Athens University, Greece, and it is my great pleasure and honor to welcome you all in this webinar entitled Renal Denervation Development Update for Hypertension Specialists. Nowadays, exchange of scientific advance for the management of hypertensive patients through web-based approach is a must. And I would like to thank Medtronic for giving us the opportunity to communicate by this way. I am happy to have with us today Professor José Antonio García Donaire, Professor of Nephrology from Spain. Welcome, José. And we hope to have a very interactive session. I will invite you all to ask questions, to share your expertise in this field in order, in the end of the day, this is the objective of this webinar, to have the opportunity for every one of us to understand which is the current status of renal denervation for the management of hypertensive patients. This is the agenda. I will provide a short introduction, and then we will discuss the latest evidence of renal denervation. After that, we will have the most interesting part of our session. We will share with you 3 questions with potential answers. You will vote which is the best answer according to your view about this topic, and we will have a very interesting discussion. And in the last part of our session, José will discuss some population questions about the renal denervation. And in the end, we hope to have a very interesting discussion with all of you. Worldwide, we are suffering the COVID-19 pandemic, and the world has a black swine. We know that this term was used to describe an event that occurs very seldom, but unexpectedly, but it is associated with severe consequences. And indeed, COVID-19 is mainly a respiratory disease, but in the clinical practice associated with a high viral blood clinical course depending on host and organism factors. In these lines, cardiovascular involvement was not rare in COVID-19 through 2 main mechanisms. The first was the cytokine storm, with this huge inflammatory reaction involving lungs, heart, and so on. And the second mechanism is through the ACE2. And we know that ACE2 serves as the receptor of the SARS-CoV-2 for the cellular entry. This latter informations raised a lot of questions and concerns about the role of hypertension with the course of SARS-CoV-2 infections. Does hypertension is associated with severe course of SARS-CoV-2 infections? Also, what are the role of RAS blockers in patients affected by SARS-CoV-2? Are RAS blockers harmful or beneficial? And last but not least, what are the consequences of SARS-CoV-2 on the follow-up of hypertensive patients? This knowledge about the role of ACE2 in the pathogenesis of SARS-CoV-2 infection has an important impact in the treatment of hypertensive patients and also in patients treated with RAS blocker in a broad spectrum of cardiovascular disease. Fortunately, European Society of Hypertension reacted very early and effectively in this way. Our president led a group of experts and published in cardiovascular research a very nice position paper summarizing the pathophysiology associated with the ACE2 in the COVID-19 infection and also in the neuronal activation. And in this busy slide, it is clearly shown the role of ACE2, not only for as a receptor of the SARS-CoV-2, but also in its way to convert angiotensin 2 in angiotensin 1.7 and angiotensin 1.9. We know that by these angiotensin 1.7 and angiotensin 1.9 counterbalance the deleterious effect of angiotensin 2. This was our first reaction in March 12. European Society of Hypertension was the first scientific society that published its position that based on the available data, there is no any reason to discontinue RAS blocker in fear of being affected by COVID-19, in fear of being have a more adverse outcome in this case. But COVID-19 caused a lot of consequences, not only in patients affected by the virus, but also in patients not being affected. And a typical example of this case was our experience about the missing visits in the emergency cardiological department. This is the Greek experience. The first case in Greece was in the first days of March, and compared to the March 2019 and to the March 2018, there was a dramatic decrease by 40% in the number of patients that visited the emergency cardiology department for various reasons, included patients with chest pain, with dramatic consequences in the course of these patients. And but now Europe opens airports, life seems to return to normalcy. We hope at least, and I think as hypertension specialists, it is our main goal, it is our common challenge to provide to our hypertensive patients the best of care. And this is our task, and this is the objective of this webinar, because cardiovascular disease remains the world's biggest killer. We know that cardiovascular disease contribute by 40 and 49% in male and female respectively in the total mortality in Europe, and hypertension continue to be the most important single contributor to cardiovascular morbidity and mortality. We appreciate here the number of deaths, thousands of deaths attributed to systolic blood pressure over 140 in terms of ischemic heart disease, ischemic stroke, hemorrhagic stroke, and chronic kidney disease. We are not happy with the high rate of uncontrolled hypertension. And this is a multifactorial process, included poor medication adherence, physician inertia, complicated therapeutic algorithm, and so on. Non-adherence are closely tied to resistant hypertension. We know very well, we have understood the last decade that many patients identified with resistant hypertension may actually be non-adherent to prescribed medication. This is true in the setting of clinical trials, but also in the real world. In this slide, we present here the number of prescriptions in different antihypertensive classes. From this data coming from UK, 9 hypertension units included 300 hypertensive patients with resistant hypertension. With the blue color, we can see the prescribed numbers of drugs. for all the major categories. For calcium channel blockers, for example, here and here, with the color, with the red color, is the detected drugs number in the urine testing. We see, independently of the category of antihypertensive drugs, 30 to 50% of patients are not adherent. And this has an obvious consequence in the control of blood pressure, in the adverse outcome associated with the non-controlled blood pressure. Similarly, in the setting of clinical trials, we appreciate here a number of randomized trials. There is a 30 to 50% non-adherence rated. This is consistent in clinical trials and in the medical practice. And we have to keep in mind that poor and dynamic adherence introduces a large variability to trial endpoints. And it's not easily this to be controlled, even with a trial design so rigorous. A typical example of a study where poor medication adherence affected the findings of the study was the Simplicity HTN-3. We know that this was the first randomized sum-controlled trial in the renal denervation, which failed to meet its primary efficacy endpoint. Renal denervation resulted in a reduction by 14 millimeters of mercury change in systolic blood pressure at 6 months, but at the same time, the sum ablation arm, the sum control arm, had a decrease in blood pressure by 11 millimeters of mercury. And as a consequence, this study was neutral for renal denervation. And of course, this large reduction in the sum ablation arm in the systolic blood pressure could be explained by the poor medication adherence, by different adherence in the medication between these two groups. And these blood pressure changes in the control group generate a lot of interest to understand and to try to adjust for these sorts of variants. After these disappointment results of HTN-3, all the experts in the field and the academy have understood that a more rigorous design of the next generation of renal denervation trials should be needed in order to address the confounders that were identified for the failure of HTN-3. At least 3 confounders had a major role: inappropriate patient population, poor medication adherence, and incomplete denervation. So this was the start point for a new start in order to get the right results with renal denervation. In this field, Medtronic redesigned the new trials, the renal denervation clinical program, and now over 4,000 patients have been studied across multiple trials. The spiral HTN off medication, the pilot study, completed 3 years ago, and the results were presented at the European Society of Cardiology meeting. The spiral HTN on medication, the pilot study, completed 2 years ago, and the results were presented at EuroPCR, and 2 months ago in the ACC meeting, virtually the off-med pivotal study have been presented by Michael Baum. Also, the ongoing trials, the on-medication trial, USA patients preference study, and the spiral distal study, along with the global Simplicity registry, will complete an extensive set of clinical data, providing evidence for the efficacy and safety of renal denervation. In other words, these new renal denervation studies, the spiral HTN clinical program, the off-med pivotal study provides scientific evidence of efficacy. The on-medication provides evidence of efficacy in a more clinically relevant population. The off-medication pivotal study has as a main purpose to address the confounding effect of poor medication adherence. And also, the Global Simplicity Registry will provide large data based on what happened in the real world about the durability of the effect and about the safety of renal denervation. One of the major confounders for the failure of HTN3 and for the huge variability in the blood pressure response post-renal denervation was incomplete denervation due to the use of the flex catheter. For this reason, the spiral HTN clinical program used the spiral catheter, which is able to deliver circumferential ablation in up to 4 electrodes. 60 seconds simultaneous energy delivery in all vessels with a diameter 3 to 8 millimeter. And this flexing catheter allows also delivering of energy in the branches. A lot of preclinical work have improved our understanding about the location and distribution of the renal fibers. We know very well, as we go from the proximal part of the renal artery to the distal one, even in the branches, the number of fibers is decreasing, but their distance from the lumen is also decreased. That means that delivering the energy close to the distal part in the branches, we are able to disrupt more fibers, in other words, to achieve complete denervation. Additionally, we know that accessory arteries, 20 to 30% of our hypertensive patients has more than one artery per side, have a similar anatomical innervation patterns that mimic the main renal arteries, and for this reason, in these new second generation renal denervation studies, we ablate also the accessory arteries. We have solid evidence that distal ablation is associated with greater reduction in sympathetic nerve activity. In the Porcine level, 3 therapeutic strategies were tested. Ablate only in the main artery, ablate only in the branches, or ablate in both main artery and branches. And we appreciate here a 71% reduction in the norepinephrine spillover when we ablate in the main renal artery only, 83% reduction when we ablate in the branches, but this percentage was increased significantly to 92% when we used combined approach. Greater reduction in renal sympathetic activity with combined proximal and distal therapy application. This is what we are doing now in these studies. Let me present it very briefly some key findings of the spiral HTN on medication pilot study and later on from the spiral off medication pivotal study. The spiral HTN on medication pilot study was a randomized, some control, blinding, proof of concept trial in 25 sites in Germany, UK, Austria, Greece, Japan, Australia, and USA. Patients with uncontrolled hypertension confirmed with ABPM, and while the patients were on 1, 2, or 3 medication for at least 6 weeks. And there was an adequate period of 2 to 4 weeks from visit 1 to visit 2 in order to confirm that the patients receiving the medication, stable medication, and the blood pressure was uncontrolled. And of course, we tested the medication adherence by drug testing the urine at the visit 2 and during the follow-up. After the enrollment, the patients were randomized to renal denervation plus medication or to some control plus medication, and were followed up for 1, 3, 6 months, and 12 months. And the average number of medication was 2.2. We see here that the majority of patients receive 3 medication, 52%. All classes of antihypertensive medication were used. And coming to the results, we were very happy to observe a significant reduction in office and ambulatory systolic and diastolic blood pressure. 24-hour systolic blood pressure was reduced by 9 millimeters of mercury in renal denervation arm, compared to 1.6 millimeters of mercury in the SAM ablation arm, resulting in a net difference by 7.4 millimeters of mercury in ambulatory systolic blood pressure. And in the office blood pressure, this blood pressure was also significant, net difference 7.7 millimeters of mercury. 9 millimeters of mercury reduction in the office systolic blood pressure in the renal denervation arm, 2.6 millimeters of mercury reduction in the SAM ablation arm. And what was very interesting was this homogeneous reduction in blood pressure throughout the 24 hours during the follow-up of 6 months. We see here that the blood pressure was reduced significantly in the renal denervation arm compared to the placebo, compared to the SAM ablation arm during the nighttime and daytime periods. Coming to the off-ment pivotal trial that was presented, as I mentioned previously, virtually in the ACC by Michael Baum. This study was very, very interesting, randomized, some controlled trial to address the confounding effect of poor medication adherence. For this reason, we selected to include patients in the absence of antihypertensive medication, but of course with uncontrolled hypertension confirmed with 24 hours ABPM and also with drug testing to confirm the absence of antihypertensive medication at baseline and also during the follow-up. The patients were randomized to SAM control and renal denervation and follow-up every 2 weeks, and at 3 months was the primary endpoint changes in ambulatory systolic blood pressure. This study, the pivotal study, utilized the Bayesian adaptive study design which efficiently leveraged data from the spiral HDN of medication pilot study to support the results of the pivotal trial. In other words, 80 patients randomized to pilot trial were included along with the 353 randomized patients in the pivotal trial in order to have a total number of 433 randomized patients. By this analysis, which was in agreement between in the industry, FDA and academia, we were able to announce results earlier and also to avoid to expose patients in the risk of SAM ablation without receiving any antihypertensive medication. And here we see that there was a significant lowering effect of renal denervation in 24-hour systolic blood pressure by 4.7 millimeters of mercury compared to 0.6 millimeters of mercury in the SAM ablation arm. Similarly, a significant and greater reduction in office systolic blood pressure by 9.2 millimeters compared to 2.5 millimeters of mercury reduction of office systolic blood pressure in the SAM ablation arm. Similarly, significant reduction, but to a lesser extent, in 24 hours diastolic blood pressure in the renal denervation group arm compared to the SAM ablation arm. And as we discussed previously in the HDN on medication trial, we also were happy to observe a consistent reduction in the 24-hour systolic and diastolic blood pressure through the daytime and also the nighttime period. Interestingly, the nighttime early morning period, we know that is a high risk zone associated with increased risk of stroke, cardiovascular event, and we were happy to see a reduction in blood pressure in the renal denervation arm compared to what happened in the SAM ablation arm. We know from the pharma trials, here is a large meta-analysis published in Lancet by Ed Hunt, that 10 millimeter of mercury reduction in systolic blood pressure could be linked to a significant reduction of key endpoints, major cardiovascular event by 20%, stroke by 27%, and all-cause mortality by 13%. That means that this reduction that we observe in the HTN pivotal study is clinically relevant. So, as a conclusion of the spiral of medication study, we can say that this study has the power to demonstrate that renal denervation could lower blood pressure compared to some control in uncontrolled hypertensive patients in the absence of medication in both 24 hours and office systolic blood pressure. This blood pressure was clinically meaningful at 3 months, with the always shown this effect throughout the 24 hours period, independent of patients' adherence to medication. And on the other hand, this clear efficacy of renal denervation was associated with no major device or procedure-related safety events through 3 months follow-up. And recently, a nice meta-analysis of some controlled trials of renal denervation for uncontrolled hypertension was published in Journal of Clinical Hypertension, comparing the effects of first-generation trials and second-generation renal denervation trials compared to some ablation. And we see here that both studies were associated with a significant reduction in blood pressure compared to the sham ablation. Last but not least are the data that Global Simplicity Registry is provide up to 3,000 patients regarding efficacy and safety in real-world settings. We are all familiar with the Global Simplicity Registry. Patients were followed up very regularly, and what is interesting is that a huge number of patients, 2,700 patients, were followed up with 6 months. A similar number of patients continue to be followed through the 3 years period, providing data not only for the efficacy but also for the safety of renal denervation. And this real-world data confirm what we have seen in the setting of clinical trials. Even after a long period of 3 years, blood pressure continued to be significantly lowering in patients treated with renal denervation. The same is true for office systolic blood pressure, but also for ambulatory systolic blood pressure, of course, to a lesser degree. And we see here a sustained drop in blood pressure based on the Global Simplicity Registry, independent of antihypertensive medication burden. There is a reduction, a trend for reduction in the number of medication, but of course, there is a significant reduction in the patients with uncontrolled hypertension. So we are happy to demonstrate that renal denervation works. Pivotal study provides solid evidence that renal denervation provides statistically significant and clinically meaningful reduction of ambulatory and office systolic blood pressure in a broad spectrum of hypertensive patients. And the ongoing trials, the on-medication trials, the distal trial, and the preference study in USA will complete this setting of data to have more evidence about the efficacy and safety of renal denervation. So, dear colleagues, in summary, I would say that now, thanks to this second-generation renal denervation trials, we have solid evidence that radiofrequency ablation delivery with a spiral catheter could result in a statistically significant and clinically meaningful blood pressure reduction compared to some ablation without major adverse effects. In mild to moderate combined hypertensive patients, in the absence and presence of the hypertension medication. This effect is always on. Blood pressure reduction following renal denervation were present throughout the day and nighttime period. And additionally, the Global Simplicity Registry provides real-world data or long-term, 3 years up to now are available regarding durability and safety of renal denervation. And so we will have more data in the near future. Without any other delay, I would like to thank you all for attending my presentation, and would also like to invite you all to attend either physically or virtually the upcoming pre-SH meeting that has been postponed from March to 11-12 September 2022 in Athens, in order to discuss the concept of difficult to control hypertension, related comorbidities, and what should be the role of renal denervation in these patients. Thank you so much for your attention. I would like to ask from you if you would like to ask questions, just to raise your hand, and I will give you space to ask your question, to make your comment, or also maybe you can write your questions in the question and answer session. And at this point, before starting the discussion, I would like to have the first question from the pooling in order to make more interactive the whole session. May I have the first question, please? May I have the first question?
Sorry for the delay.
Okay, sorry for the delay, but I am sure that the technical staff will show very soon the first question that we have selected along with José 3 questions to have your opinion and to start the discussion. Okay, this is the first question. The blood pressure reduction presented in the spiral HTN off medication. First, 5 choices. Strongly disagree with this, disagree, neutral, agree, or strongly agree. You can submit your answer, and then we, along with José, we start to discuss your potential answers. Please start to vote.
I believe the end of the question got cut off. So the question should be, the blood pressure reduction presented in the spiral HTN off med is clinically meaningful.
It's missing
Yes.
some sentence. Okay, the blood pressure reduction presented in the spiral HTN off med is clinically meaningful. What someone should strongly disagree, disagree, neutral, should agree, or strongly agree. Okay, 67 has already been voted. Okay, 62%. José, would you like to comment the response?
Yes. Hello, everyone, and hello, Kostas. Thank you for being here with us. I have also answered this in the same direction. I think it's clinically meaningful. And later in my presentation, I will show you why. But I think it's in the line that we see in our patients in consultation. Maybe we can mix the thoughts between the patients that we are used to see in our clinical and those in the clinical trials. And I think that those are not the same kind of patients. If we could translate these results into the real patients, I think that these results would be much more meaningful even with these results. I don't know if you agree with me.
Of course, I agree, but I would like to ask someone of the participants who vote in favor of the neutral, this blood pressure reduction has a neutral effect in terms of reduction in the cardiovascular event, to comment and to have his opinion. Please feel free to make suggestions and to provide your thoughts in this issue, because in the end of the day, this is the most important. This is the reduction that the renal denervation could achieve. There is consistent findings, independently of the technology that we use, independently of the population settings in patients with medication, without medication. This is the blood pressure reduction. About 10 millimeters of mercury in office systolic blood pressure, I mean average blood pressure reduction, and about 5 to 7 millimeters in ambulatory systolic blood pressure. Of course, we know, based on the clinical studies, but also based on our personal experience, because we have experience for a decade now about renal denervation, that some patients are very nice responders, some others are not responders. In some cases, the blood pressure continue to rise even more after renal denervation without a clear explanation. This is the problem. We are not able to identify based on a specific phenotype who should be the responder in order to get greater blood pressure reduction in all hypertensive patients. So I would like to have any comments from the participants. Anyone?
Maybe anyone who voted for a neutral clinical effect would like to share the thoughts or their conclusions of this vote.
But also,
Yes.
I am not sure that if you can see if someone raised the hands, because in the list of participants I can see only the panelist. Yeah. I cannot see.
Professor Mancia.
Yeah, Giuseppe. Thank you for attending the session. Could
Please
you
go ahead.
Unmute your phone? To be taken off mute, please raise your hands. While we expect Giuseppe questions, there is another question to discuss. Is the cost worth this degree of lowering of blood pressure? This is another expression of the same question. How much clinically relevant is the blood pressure reduction? We have clear evidence from the pharma trials that even 2 millimeters of mercury reduction in systolic blood pressure could result in 7% reduction of cardiovascular event. So this reduction, independently of the way that we could be achieved, is clinically meaningful. And of course, we have to see this in the long period of time, not only during a 3 months follow-up period that there is no adverse events. So I think we need such studies to estimate the cost effectiveness of renal denervation, but based on the previous experience from other devices in the cardiovascular field, I am quite confident that this should be cost effectiveness, taking into account that the contribution of hypertension, of high blood pressure in the cardiovascular and events is so enormous.
I think Professor Mancia can
you hear me now?
Yes,
we can hear you.
Well, I voted I agreed that 10 millimeter mercury reduction in office blood pressure and 6 millimeter mercury reduction in 24-hour blood pressure is clinically meaningful. It corresponds to reduction in cardiovascular events, substantial reduction. But this evidence has been obtained in largely in people with non-resistant hypertension. So I think vital information would be to know to how much 10 millimeter mercury reduction in resistant hypertensive people reduce cardiovascular events. Specifically, I think this is going to be very difficult. I understand this, but I think it's would be a very important information.
I absolutely agree, Giuseppe. Thank you very much for your comments. You know that renal denervation has started from this difficult setting of resistant hypertension, but in order to eliminate the confounded effect of medication adherence and changes in medication, we moved to the off medication. But I think now it's time, this is for the future, also this setting of difficult to control hypertension and resistant hypertension to be tested to see what should be the blood pressure reduction. On the other hand, based on the on-medication pilot study, we have evidence that patients with on three medication also we observed the same reduction in blood pressure as in off medication. This provides a very preliminary evidence that maybe the same would happen in resistant hypertension. But I agree, we don't have evidence. We need evidence in this field.
Also, in the Donaire HTN study with resistant hypertension, renal denervation in a control group or in a methodological study proved that had a reduction of blood pressure, a significant reduction, but we need more data on these patients. Anyway, if you, Kostas, let me, maybe Maria Dorobantu also wants to speak.
Okay, Maria.
You have
Maria,
to unmute.
In the meantime, just another comment. I think this general problem is not a problem of renal denervation only. We really do not know the relationship between blood pressure reduction and reduction of mortality in cardiovascular events, even in resistant hypertensive under drugs. So this is a chapter which will have to be addressed, not only for renal denervation, but also for pharmacological treatment.
You are absolutely correct, Giuseppe. This information are missing even in the setting of pharmaceutical trials. Yeah, Maria, do you hear us? If not, there is one more question asking if spironolactone could be tried before renal denervation. We know the results of the pathway 2 and also of the REHOT study that addition of spironolactone or eplerenone in patients with resistant hypertension could result in a significant reduction in blood pressure. But also the average reduction compared to the other drugs, to the beta blocker or to doxazosine, was only 4 millimeters of mercury. Do not expect miracles by the addition of spironolactone. But of course, it's a choice, and the guidelines, this is what they recommend in patients with resistant hypertension. I think we have to move on to the next question in the pooling, and then to come back for comments and discussion. May I have the second question, please? A major advantage of renal denervation is that it's always shown consistently lowering blood pressure in contrast to the pharmaceutical effect on blood pressure, which relies on patient compliance. Strongly disagree with this proposal? Disagree, neutral, agree, or strongly agree? Start to submit your vote. Can we see the results? Okay, José?
Mostly agree. Yeah, we have more doubts than answers in this field, at least with the data of the Global Simplicity Registry. We can be sure that at least with this data, the maintenance, the latency of the effect is consistent across 3 years, and that is quite important. But we need to know what happens with more ABPM study, with more observing the deepening effect, observing the ABPM evolution in the year 1, 2, 3, and more. And that is lacking also in pharmacological studies, but we need to know more about what patients will be best responders or those that need another dosage of RDN in the time. We don't know, but we must study that.
Yes, I think that although there are data supporting that nighttime blood pressure is superior in predicting cardiovascular effects, we recognize that these data are not enough in order to have a definite answer in this problem. But on the other hand, we know that morning cells, also non-deepening status, and the blood pressure level during nighttime has consistently related with adverse outcomes. So it's good to have an homogeneous reduction in blood pressure, and this is the issue for selecting long-acting drugs in order to cover all the 24 hours. If someone from the ABPM...
Maria, you should be able to speak right now. Maybe you can try. Maria. The sound that isn't working properly.
Yeah. We have two questions in the meantime. What was the number of non-responders in the spiral trial? The non-responders in all the spiral trials is about to 35%. This is a consistent finding. And also, was visit-to-visit blood pressure variability assessed in the registry? In the Global Simplicity Registry. If Giuseppe would like to comment on that, because recently has published data from the Global Simplicity Registry, we will be happy to hear his thoughts. Giuseppe? Professor Mancia? We have, while waiting Giuseppe to come back, I would like to say that we have data from single center studies that renal denervation could reduce the blood pressure variability. Also, there is a meta-analysis published in the Journal of Hypertension last year showing that renal denervation reduced the blood pressure variability. We know that there are methodological issues how to assess blood pressure variability, short-term, long-term, and visit-to-visit variability, but at least short-term variability is reduced by renal denervation, and also this may add to the cardioprotective effect of the lowering effect of blood pressure by renal denervation.
Yeah. Can you
hear?
Giuseppe? Yeah, so, well, this is another aspect of the global registry, which is likely to produce interesting data. That is on short-term variability and visit-to-visit variability. The problem is there for both variabilities, however, because there is evidence that short-term variability is an independent cardiovascular risk factor. Also, that visit-to-visit variability can be an independent cardiovascular risk factor, although there the problem, methodological problem is a bit greater. What we really do not know is whether for short-term variability, reduction of variability by drugs is accompanied by reduction of cardiovascular events. And the same is true also for nighttime blood pressure. We know, as Gio Costa pointed out, that nighttime blood pressure is associated with a greater effect on cardiovascular events than daytime blood pressure. But we do not know whether lowering nighttime blood pressure is associated with a greater degree of protection. There have been some studies published in the European Heart Journal, but there is some criticism around this study.
Okay. Thank you, Giuseppe. I think it's time to move to the last question before going to the presentation of the clinical scenario by Joseph. Okay. The results from the Medtronic spiral HTN off-med trial cannot be translated to other renal denervation device. There is no class effect. Strongly disagree with this position, disagree, neutral, agree, or strongly agree. This is important if there is class effect of renal denervation or this effect is related to this spiral catheter to the delivery of radiofrequency energy. We can submit our answers now. Could the host show us the results? Okay. Jose, you are the first.
I'm happy that I have voted with the most of the assistant the 3 times. I think it's neutral because I perceive what I see and I believe what I think it's important in the evidence. And I have no experience with radiance or with ultrasound ablation, but I have experience with renal denervation, with radiofrequency. And I, of course, know that there are a number of non-responders. I think we have to go on studying what happens once a patient receives this treatment in the short, in the mid, and in the long term. We are having not only experience, but evidence in real clinical times, in real clinical office, but also in clinical trials, patients with and without medications, patients with resistant hypertension, diabetics, sleep apnea, elderly, and so on. I think, I don't know, I feel neutral because I don't know what is the relevance of this treatment to patients in the long term. But first, I included my first patient in 2009 in HTN2 study. I have observed the evolution throughout these 11 years, and I have this experience, and I don't know if this would be or could be achieved with other treatments with denervation of the renal arteries. So I would be so happy to have this answer to this question, but today I cannot. So I feel neutral in this.
Yeah, I think this is a very difficult answer in this question because it's the same we have also with the drugs. Are all the ACE inhibitors the same? For example, are all the ACE2 or the calcium channel blockers? We know that we believe that they have a class effect, but also there are difference between different individuals. In what we know that now that there is consistent blood pressure reduction independently of the technology that have been used in the Radiance solo study and also in the spiral pivotal study. We observe similar, less or more reduction in blood pressures in similar clinical settings. But what is interesting that these results in the spiral project was achieved by this specific therapeutic ablation strategy, ablating in the main and also in the branches, maybe by a different strategy of ablation of delivery of energy, we can obtain better or worse results. So
Yeah.
up to now, our knowledge is based on this specific strategy by using this specific catheter. So we need more data to have a better approach in this issue.
Yeah, hitherto we have a more homogeneous way of making renal denervation, not only in the on-med, but off-med and pivotal. We have patients with more or less the same dosage of ablation of renal denervation, and we can compare the evolution. The problem, the issue was that with different ways of ablation of denervate renal innervation, is difficult to compare or to state a class effect. I agree with you that also happens with the dosage of the pharmacological class of drugs, and even with the different active principles in the class of pharmacological drugs. But anyway, we have to deal with it.
If Maria now could ask her questions or her comments, is that feasible? If no, José, I would like to ask from you to share your presentation with us, and then to have some time for the final discussion and final comments. We are looking forward to hear you.
Thank you, Kostas. I have 15 minutes to share with you some information, to have some objectives together. All of us are specialists in patients with arterial hypertension, but we know that sometimes we are asked about what would be the number one risk factor if we had to stop one of them, to control one of them, because many times we have patients with many uncontrolled risk factors, and we should choose one of them because it would be most effective in order to decrease the possibility of morbidity and mortality, and even healthy cost would be arterial hypertension. We know how to deal with it. We know how to diagnose. We have very important therapeutical tools to control, but we don't have good levels of control worldwide. We can choose any country in the world, and the levels and the numbers would be very similar, with the prevalence increasing with age, with prevalence increasing with other cardiovascular risk factors, and not many countries with a control rate of blood pressure in arterial hypertension be higher than 40%, 45%. So we have most of our hypertensive under known control levels. And we have non-pharmacological treatment, very important. We have pharmacological treatment, and we have device-based treatment. And we know about renal denervation. But if we are talking about renal denervation, if we observe what happens with renal denervation, at least in a theoretical way of seeing it, we could decrease sodium and water retention, we could decrease renin release, and we could enhance renal blood flow, because we could ablate the renal afferent sympathetic activity. That is theoretical, but what happens in the real patient? What happens if we observe the result in patients that have been treated with renal denervation? But it depends. But that's why the answer to the question done before is difficult, because It depends of the anatomy of everyone, of every patient. It depends of the dosage of ablation, of radiofrequency. It depends of the previous state of the arteries of the patient. It depends of a number of variables, so difficult to make homogeneous in order to compare, but we have to do it. We have learned that if we go distal, the interventional cardiology goes distal in the renal arteries, the rate of sympathetic fibers would be the most prevalent or the most frequent there, more than parasympathetic or even afferent. So that's the reason why we should be in the intervention hall, and we should encourage the interventionist to go to the distal branches and to the distal arteries, because we know that those might be the most with the sympathetic fibers, and that it's important in order to decrease blood pressure. But the question was, what would be the preference of patients that undergo renal denervation? And we can make these groups, these three groups. Those who are not controlled despite drug therapy, this is the main group that has been studied in the last 10 years. Later, those who prefer renal denervation, I think that with the high prevalence of hypertension, it's quite rare that we haven't had the consideration of the patient in order to their preference. I think that other pathologists and other specialists, maybe endocrinologists in diabetes, maybe other pathologists, dermatology, and so makes the importance of the patient's preference in order to choose a technique or a drug or a non-pharmacological treatment for a chronic disease. And I think it's important. What does the patient prefer for the treatment of his or her pathology, and in order to explain the possible collateral effects and so. And the last group would be those who are intolerant to medication. We know that is a important number, especially when we are treating or we are working daily with a hypertension unit. An additional consideration should be the adherence, of course, the comorbidities, the age, the cardiovascular associated risk, the specialist characteristics that have been studied in the clinical trials, and of course, a special type of hypertension that is a neurogenic hypertension, and the profile of the high sympathetic activity. If we take a look at the first group, we would be agree, and otherwise I would like to hear your comments that we are not, we have not a very big number of patients with grade 3 patients in our hypertension unit, but the most of the patients, the highest number would be those with grade 1 and asymptomatic disease and stage 2 hypertension disease staging. And this group of patients has been studied in the groups of the global registry, because the age of the whole group, of the whole cohort, would be 61 years. The office systolic blood pressure is quite recognizable. In 166 is systolic, 154 in the ABPM, with a four number of antihypertensive meds. I think I can recognize a big number of patients that are in this situation, in this scenario, in my consultation at least, and the results can be for all of these groups: resistant, elderly, diabetic, isolated, systolic, chronic kidney disease, and IF. And I think it's important. And the results just published a few weeks ago is consistent across the 3 years in most of the groups. A number of them, those with chronic kidney disease, with the lesser numbers, but consistent across the years. And the resistant hypertension group has reached minor 23.5 millimeters of mercury. I think quite important in the overall cohort. So that's one of the main questions that always arises when we are talking about a device-based treatment in any kind of medicine, or in any specialist. Safety is guaranteed. That's important in the clinical trials and in the global registry. I think this is one of the reasons that the technique has evolved during the last years, although it has some issues with HTN. But safety is guaranteed, but not also safety is guaranteed, but renal function is maintained. We can see decline in kidney function, in renal function, very similar who hypertensive patients with high risk would be in the real life, 1 to 3 millimeters minute a year, and that's what happens to patients that has received renal denervation. That is also, in terms of safety, very encouraging. And as we said before, the 24-hour ABPM has shown that patients who are treated with RDN has a good profile compared to those with the sham treatment. And I think it's also something that we have to study in the next year, that high risk zone in the very early times of the day. No, I think it's quite important. That what happens to those who prefer renal denervation? I think that as Professor Tsioufis has said in his presentation, it's important to take into consideration the adherence of the patient, and I say the preference. We are going to conduct in next autumn the one polling questions in Spain, and we would see what happens when you ask to the patient if he could be treated with a single procedure, with a device-based procedure, what we choose. In Germany, we have this data presented by Professor Schmieder. Is 38% of the patients would rather choose a single procedure better than a drug therapy. And I think it's the first stone of something that we have to move on in the next years. And when we see what happens when a patient prefers something, is because he doesn't like to take pills. But those who are fully adherent, for example, in the OnMed study spiral, the results are much better. Patients who take pills have better results. That I think is obvious, but we have those data. And it's a honor for me to show this slide from Professor Mancha, who is with us today, that what is the relevance of this data? Because some colleagues can ask if this is meaningful or not. But I think that when we see 10 millimeters of mercury in the decrease of 24 hours systolic blood pressure in ABPM, it translates into 15 millimeters of mercury change in office systolic blood pressure. And I think it should be important for the prevention of cardiovascular events, but we have to show it. We have to make that conclusions. What happens in the OFMED? We have seen in the brilliant presentation of Professor Tsioufis. It's important to observe that renal denervation alone can decrease blood pressure in a significant way. That's important. And the last group of patients who would be those who are intolerant to medication. And this is the point where adherence to treatment is important, because we have seen that many patients are not controlled, even taking pills, even taking treatment. It can be the decision of the physician that hasn't chosen properly, but sometimes it's because patient doesn't take the pills. And I think it's important to observe, to ask the collateral effect taking pills, but not only with spiral, as we can see here, but only with radiance, with ultrasound ablation or ablation of renal denervation, has observed decrease of blood pressure in 3 to 6 months. So it's important, not only patients taking pills, but also those that are not taking pills, that has an effect in decreasing blood pressure. And I think it's important. And I will finish my presentation with a quick clinical case. It's a male in his early 60s with everything that you can imagine in collateral effects: dry cough with ACE inhibitors, severe edema with several calcium channel blockers, diarrhea with indapamide and other thiazide, orthostatism with doxazosin, gynecomastia with spironolactone, and fatigue and bradycardia with beta blockers. Several admissions to hypertension crisis, type 2 diabetes, and dyslipidemia, so high cardiovascular risk. And this is his ABPM registry with HTN 1 to 2 grade in activity and at night. And this is the patient was chosen for renal denervation. You can see here the left kidney. You can see what I said before in the anatomy. This is not a perfect anatomy. We had to be in the with the interventionalist and observe that we needed to go distal and also proximal with 2 main arteries, also 2 branches. You can see here in the next slides with the spiral. We performed, I think, 22 ablations in the left kidney, and you can see here, I think, the right one, the right kidney, also with an anatomy, a difficult anatomy, with the 2/3 of the kidney with the perfusion of one double anatomy of the renal artery. And then you can see the spiral here, and also the inferior pole of the kidney with other main renal artery that was also ablated with the spiral. We performed there 24 ablations, and the result was fortunately quite good. At 6 months, we had a significant decrease of the blood pressure, and the patient felt quite better. And finally, I can share with you the two the 2 proposals that have been published worldwide, not only in Taiwan but also in Italy, to state what would be the patients prefer for RDN, that are in Taiwan publication resistant, those with organ damage, those not adherent, those intolerant, and those with withdrawn of secondary cause. And much easier, maybe because it's this algorithm of the Italian Society of Hypertension and Cardiology that has to have a global cardiovascular risk assessment, often as 24 hours BP, screening for secondary hypertension and withdrawal of that, shared decision-making with the patient, and drug adherence and tolerability assessment prior to the optimization of the treatment. And then if it's candidate, with a multidisciplinary staff, the evaluation for RDN, or if not, the clinical follow-up, that I think it's quite important. So I can conclude that patients with many clinical situations must be identified and appropriate selected with optimization of the procedure and the combined management of antihypertensive drug regimen and RDN. Patient preference should be included in therapeutic decision. RDN must be included as an option among those who are intolerant to drugs and has to be proven to be safe in the short and mid-term. Patients included in the spiral of med pivotal must be also included as good candidates as more evidence is coming. And RDN is a safe and efficient therapeutic tool in hypertensive patients must be included in the routine decision-making for hypertensive population. And thank you very much. And I think we can pass to the questions.
Thank you so much, José, for this very nice, practical and realistic approach to this issue. And I noticed that all the consensus that you presented have three key words. The first, difficult hypertension to be controlled. Second, patient's preference. And third, intolerance to drug. Among these three, let's say, groups, which one for you, as a practical physician, as a nephrologist, is the most important? What makes sense in the clinical practice?
It's a very good question, Kostas, but I think in my experience, we have performed, I think, more than 50 RDNs, and most of them have been patients with high cardiovascular risk that can't be controlled with the usual treatment, even when spironolactone has been added on to the treatment. This is an increasing number. We have a good multidisciplinary staff, not only from the point of view of the selection of the patients with the GPs and also with the hypertension unit. We have a close relationship, but also with the interventional unit. And we have an important follow-up protocol. All of us are in the same direction with the patient. The patient knows what is the possibility of being treated, what would be the possible effect of the RDN, and even that it doesn't make a good effect, that is a possibility that doesn't respond to this treatment, we should have to go on studying and seeing what happens in the future. So I think this group would be the most frequent.
Maria Lorenza Moisan asked a question. Hello, Maria. In the German registry by Roland Schmitter you presented, what are the characteristics that the patients hand those who prefer the renal denervation? If you have information about what type of patients, the profile of patients that prefer renal denervation in the German registry.
Is for me the question or for Maria?
For Maria, from Maria.
Oh, okay.
Maria asked what are the profile, what are the characteristics of German patients who prefer renal denervation instead of medication. If I could say a word, this is most of patients with mild stage 1 hypertension who could be able to control blood pressure hypertension only by renal denervation. We know that those patients, there are a certain portion of patients who don't like to receive medication. This is true, and this is what the explanation for the faster enrollment rate in the off-medication spiral study compared to on-medication. If you offer to a young patient, to a newly diagnosed patient, a possibility to receive for all life 1 or 2 medication, 1 or 2 pills, or to undergo a single minimally invasive procedure, 1 day hospitalization or half a day, I am sure that at least a significant portion of them would be more comfortable to undergo this procedure. Of course, we all agree that we need more long-term data about the efficacy and also of the safety of renal denervation, but it's very, very encouraging the fact that at least up to now, during 3 years follow-up, there are no any concern, as Professor Donaire explained, about the safety of this procedure and about the deterioration of the kidney function. Do you like to comment a little bit about the durability, Jose, of the blood pressure reduction, about the regrowth, anatomical or functional regrowth of the renal fibers? What is your feeling as a nephrologist?
We have data in animals, in preclinical studies. Even we have observed re-innervation in as I say, in animals, but not in humans. At least not re-innervation that is clinically meaningful. However, we have seen patients, as you said before, and I agree with you, more or less 1/3 of the patients that aren't responders. We don't have a clinical tool to know what patients would be the best responders, and we don't have a tool to observe what happens after the denervation. We need it. We have discussed about this issue even with Professor Murray Esler in Australia for some months and years, and it's quite difficult to be able to have it in the short term. But it would be great to know if the dosage of the renal denervation has been enough in order to expect that the BP is going to be homogeneously decreased, as we have seen in the registry. But it happens that some data that has been published is not the same that in the global registry, and that's why we have to study more.
Yeah, at the same point, you would be more interested to see in the near future long-term safety data or long-term efficacy data of renal denervation. Of course, both of them would be the ideal scenario, but from a nephrological perspective, you are more interested in safety during long-term or about the efficacy?
I have included one slide from Felix McFoot et al. Just published a few days ago in JACC with the renal function slight decline, more or less the same that would happen in the real world with those patients that are also treated with ACE inhibitors or ARBs. Many of them are also treated with spironolactone and polypharmacy. So it happens, and it doesn't make a significant decline as we could expect because of the treatment with iodine contrast in high-risk patients with possibility of having atherosclerotic arteries. As you have seen, the anatomy of difficult access and the possibility of having complications is there, but we haven't seen. So if I have to choose, of course, I choose safety, but also I know that efficacy is there, because otherwise we couldn't offer this treatment.
Yeah, I think your reference about this recent publication by Felix in JACC is very important, showing that the renal denervation is equally effective among patients with different level of cardiovascular risk, elderly, non-elderly, over and below 65, in diabetic patients, in patients with isolated or systolic diastolic hypertension, because in the beginning there were some concerns about the efficacy of renal denervation in the field of isolated systolic hypertension due to the stiffness of the arteries. And I think this is an important message for the future, take into consideration the potentially pleiotropic effect of renal denervation beyond blood pressure reduction in the organ damage, in the regression of left ventricular hypertrophy, in the improvement of arterial compliance, and also in the atrial fibrillation. This is another very hot issue related to uncontrolled hypertension, and this is new areas for further research and for renal denervation, particularly in hypertensive patients at high cardiovascular risk, and preliminary evidence support that this also would be an ideal candidate for renal denervation.
Of course. I think that it's also important to have a therapeutic tool that is safe and can be included in some cases to patients that cannot take any pills because of intolerance. And this is maybe not a huge number of patients, but all of us know that it's quite difficult to treat patients. Those patients that are wandering in some consultations in cardiology, in endocrinology, in nephrology, and GPs, internal medicine, and no one knows what to do. And this is, I think, is an opportunity with the OFF-MED study to know that those patients have hope, at least, to respond to a technique that is safe. I think it's important to highlight that.
José, and by this statement, I think that it's time to end this webinar. We have to conclude that based on this evidence from the new second generation renal denervation studies, in particular from the Spiral HTN clinical program, we now know that renal denervation works, and renal denervation could be the third pillar, along with lifestyle modifications, along with medication, in the management of hypertensive patients, in those who difficult to control with uncontrolled hypertension, in those with intolerance to drugs, in those with specific preference to undergo a minimally invasive procedure. I am sure in the near future we will have more opportunities to discuss more about this as we will have new evidence. Thanks so much all the participants for joining us. Thanks once more time Medtronic for giving us this opportunity. And on behalf of my co-chairman, co-coordinator, Professor José Antonio
Thank you,
Donaire, thank you again for attending this webinar. Have a nice
very
night.
soon.
Bye-bye.
And please be safe there.
Be safe.
Bye.
Bye.